Dr. Kelly Graham is just a wonderful, caring, inquisitive general internist and clinician educator who also has very important roots here in DC and in fact here at Georgetown, having graduated from the Georgetown University School of Medicine. She then went up to Beth Israel Deaconess Medical Center in Boston for her residency and her chief residency. And she was, in fact, my ambulatory chief resident when I was an intern there, and was such an impactful mentor and is probably one of the reasons I pursued a career in primary care. Dr. Graham completed her general medicine research fellowship and got her MPH at that Harvard combined program. And she's currently the director of BIDMC's ambulatory residency training program and the separate primary care track as well. Her main area of research focus is very near and dear to all of us in academic medicine, which is the impact of structural inequities within academic medical centers on vulnerable patient populations. Not a topic that's just specific to us here in GIM clinic, but actually pertinent to all of us here in the Department of Medicine who work with resident and fellow trainees. So thanks so much for joining, Dr. Graham. I'll let you take it away.
It's such an honor to be here after, I can't believe, 15 years since I've graduated. It's still, I think, the most formative place for me in my formation as a physician. After you leave Georgetown, everywhere else just feels like skills training, to be quite honest. So I think that the road that I pursued eventually in medicine is very reflective of the culture of the place I trained. So, and I'm also honored to carry on the torch of Dr. Haddad's legacy. She sounds like an incredible generalist. So I am planning to cover this. So we're going to go through the pathophysiology of structural health inequities. This is how we learn as physicians. We think in arrows. We like to really understand the root causes of how things develop. And so I'm going to try and show you how I teach this to the residents so that if you leave with nothing else today, you'll have a lens on how to detect these in the programs and structures that you practice in, and also can potentially avoid creating them in the systems that you build and the programs that you build. Because many, I'm sure, on the call already are or will be at the leadership table, working to improve your clinical programs. And it's incredibly easy to create structural inequities. And I think that's an important thing that I always keep in mind, that if you're not actively designing against them, they can sneak up on you. So then we'll move on to the body of the talk, which is where I'll focus on an example of this within academic medical centers. So specifically describing how the training mission has some unintended consequences of exacerbating health inequities. And finally, I'll share our intervention work. So you'll have some ideas if you find similar themes in your program, but also I'll try and teach you the framework of how I think about equity work so that you can apply it in multiple different scenarios. And I'm going to try and do this in a narrative form because I think when I go to these talks, I always learn just as much about how people take their inspirations and ideas and transform them into actual projects and careers as I do from the science that they produce. So I'll try to infuse a little bit of that as I go along. So let's begin in 2011, which is when my work in this area began. That may have been when Miriam and I shared an office too, potentially. At this stage, I had just finished my residency, my chief residency. I was a research fellow, and I was basically a fully trained hospitalist at that point. I wasn't yet really a primary care doctor. And I was experiencing the daily tension of meeting quality measures and trying to provide excellent patient care at the same time, which is a newer challenge when you become faculty and you're done with your training. And for my job at the time, that meant trying to do a really good job taking care of hospitalized patients who had multi-organ failure in the hospital and incredible social vulnerability outside of the hospital, like we do at academic medical centers around the country. And each time I would discharge them, it felt like I was throwing a Hail Mary pass. I knew that while their medical illness had been stabilized just enough, that their social ills would eventually metastasize when they would arrive home, unable to carry out the very complex discharge plans that I had set out for them, and that I would soon see them back as a bounce back or a readmission, and that would be considered a failure to providing good quality of care. And I also knew that the pressure to reduce length of stay was exacerbating this, preventing me from addressing some of these social issues during their hospital stay to give them a better chance of success. And this was all actually causing a significant amount of moral distress. And it was in this distress that my academic interest was born. I began to wonder, how do the systems we design improve quality, and how do they actually impact the most vulnerable patients we care for? Are they helping them or are they hurting them? And so I started my work evaluating the impact of the hospital readmissions reduction program, which is a value-based purchasing program that I'm sure everyone on this call knows very well. It links financial incentives and penalties for readmissions. And I stumbled upon the work that's featured here in the slide, which kind of validated what my sense was and what I was feeling, which is that the poorer the patients are, the more likely they are to be readmitted. And as a result, the hospitals that tended to seek the hospitals that they tended to seek care in would end up bearing the majority of the financial penalties. And so essentially, we were punishing the poorest hospitals for caring for the poorest patients. And this fueled my sense of inquiry and actually laid the groundwork for my forthcoming projects, which was the beginning of my academic career. But before we do that, I want to just do a brief interruption and review with you the pathophysiology of structural health inequities. And before I do that, I just want to go through some definitions so that we can be on the same page about some of the terms that I'll use in the presentation. So disparities are differences, and inequities are differences caused by injustice. And we've really moved more toward using this term because it does a better job at communicating what we're talking about when we talk about disparities. A health inequity, therefore, is a difference in health outcomes that is caused by an unjust barrier for a patient to access opportunities for medical care. And opportunities is the important word here. Structural health inequities are the things we do. So we come into the system as humans, as social beings, and we make things like policies and structures and care pathways. And those can sometimes, by accident, sometimes intentionally, depending on what you're talking about, what area you're talking about, limit access to health opportunities for historically oppressed patients or groups. And so we're really going to be focusing on this issue of structural health inequities. And so if you're thinking about how this happens, this is an oversimplified paradigm that I'll show you. There are two types of factors that influence human health. There's biological factors and social factors, or the man-made factors, the social determinants of health. When you're evaluating relationships and variances within a population, these you should really stay, these two issues should really stay in their lane. They shouldn't cross. Biological outcomes should only be predicted by biological predictors, and social or structural factors should really only predict social or structural outcomes. And we know that that doesn't happen, but this is what should happen under ideal circumstances. If these conditions are met, then biological outcomes distribute evenly in the population across different social conditions. And this is an example of data where you wouldn't see a healthcare inequity or a health disparity as a result, if the rules are being followed. If they cross, like what you see here with the orange arrow, this would be evidence of a man-made social structure interfering with this natural relationship, interfering with access to health, resulting in the biological outcomes being different among the two socially constructed conditions. And now, when you look, you'll see this health inequity emerge along these two social strata. And so this is what you're seeing, for example, when you see a racial disparity, for instance, in cardiovascular outcomes. Race is a social construct. It's interfering with the progression of heart disease, resulting in a health inequity when there's really no biological basis for that. So if you look at the hospital readmissions reduction program, what we're seeing here is the kind of natural process of disease activity predicting the frequency of disease exacerbation being influenced by poverty, which is a social factor. In and of itself should have no biological impact. And so therefore, the HRP is a man-made policy that restricts access to high-quality medical care to poor people, disproportionately punishing the hospitals they visit financially and deepening the inequities. And this is what led to my first set of research questions. Are readmissions really good surrogates for high-quality clinical care, or are they just measuring social vulnerability? And so we published 3 papers in the following 3 years that looked at this pretty closely. And we found that after about a week, readmissions are actually measuring social vulnerability. In the first week, they're doing a really good job measuring how well we're doing in terms of our medical management. Are we making errors? Are we discharging people too prematurely? And then after about a week, if you look really closely, they're measuring things like poverty, health literacy, getting access to medications in a timely fashion after you're discharged, having someone at home to help you convalesce, rather than being a straightforward measure of optimized medical care. And so this is actually the stage where my career took a turn. So for a variety of reasons, I needed to reduce my research footprint. And there's a whole episode on curbsiders if you're interested in that story. But I took a job as the director of ambulatory residency training at this stage, where my role was essentially to run the ambulatory training program. And with that, the beloved resident clinic. And this is where things really, in my opinion, start to get interesting and less straightforward. So here begins my foray into academic primary care, which is a whole different system than hospital medicine. Different performance measures, different structures to deal with. Instead of length of stay, everybody was really excited about cancer screening metrics and chronic disease management, cardiovascular prevention. And I couldn't wait to get my hands on some of this data. I was also anxious to do a good job as the residency program director, and I was curious to see how the residents and their patients factored into all of this. So had anyone ever looked? So I asked the population health leadership if they could give me the data stratified by faculty versus resident. And I got some really funny looks, almost like I was opening Pandora's box. But I persisted with them, and they eventually did give me the data, and this is what landed on my desk. So for nearly every measure, the residents were performing 15 to 20 percentage points below the faculty. And I looked everywhere in the literature to see if anyone else had studied this, if there was anything to guide me here. And I could find nothing, essentially. I asked around town, and people kind of had the same reaction, like, nope, we haven't looked, we don't want to look, and sort of moved on. And so I did what I usually do when I panic, which is say that I was going to make this go away as fast as I could. That was the order. And so at the time, I had my program director hat fully in place on my head. I hadn't yet learned how to integrate my professional identities. I had done all this work in health inequities, and here was one staring at me in the face, and I really wasn't seeing it that way. And so I approached the problem in the most obvious way, which was that I, the former chief resident, was going to teach this out of the residents. I was going to use all my fancy adult learning theory tricks. We're going to flip the classroom and do case-based lectures, and I would fix this with a world-class curriculum. And I would have this all done in one academic year, and then we would never speak of it again. And so here's what happened. We had a pretty neat paper to publish in the medical education literature, and absolutely nothing to show for it for patient outcomes. And this is something that happens frequently in medical education, where we, as scientists, we center ourselves on the learner, designing studies around the acquisition of knowledge, rather than centering on patients and their outcomes. We call those outcomes higher order outcomes, and we try to stay away from them. We shy away from them. We don't power our studies or design them to do that type of work. We leave that to other people. And as a result, we don't see a lot of our stuff bring forward actual improvements in patient care. And this was really creating a sense of cognitive dissonance for me. I didn't want my career in education to be kind of in this siloed, stay in your lane mentality. I wanted to continue to work under the paradigms that I had trained under in health services research, where I centered on patient care. And so I decided that I was going to try something a little bit different. While I was excited to be able to manipulate the didactic learning environment and optimize knowledge acquisition and do all of that, it was simply not enough. I wanted the success of my teaching and my teaching programs to be reflected in the care of our patients. And interestingly, the reason I tell this story is because I think a lot of people say these kinds of things. My mentors in med ed and in health services research were both saying the same thing to me, which was that I couldn't do that I had to stay in one lane or the other, that you don't do both, that there's no funding for both, that if I do both, the Harvard Promotions Committee will just be too confused about what my area of expertise is. It was just too much. And actually, when I went up for assistant professor, they sent my CV back like 3 times because they just couldn't get their head around what I was doing. But I knew that there was a path forward here, that at heart I was both, that I trained in both, and that there was important work to be done at the intersection of these two identities, these two professional identities. And this is where I sort of learned to don both hats, the educator and the investigator hat, and do this work around integration, and that's actually where our true talents develop. I think when we can bring those pieces of ourselves together, there's usually some magic there. So from this point forward, I would forge a new path at the intersection of medical education and clinical investigation, which is not technically allowed. But I didn't care. I was going to center on this incredibly important dyad, which is the learner and the patient. And I had to get back to the drawing board on what was going on with the resident clinic, figure out what happened. So I did, I used something called a contributing factors analysis, which those of you in QI will know well. It's a really wonderful way to sit down with a problem and try and figure out what's going on. Usually what's going wrong is complicated. It involves multiple things and multiple intersections. And so we started by thinking, okay, physician, patient, system, what are the things going on that could be contributing here? We had already evaluated the main physician factor, which was that these were physicians in training. Perhaps there's a training gap. They just don't know what they're doing. They're too junior. But if you look a little bit closer at the outcomes, the residents are actually, you can't tell on the slide, but they're performing at or slightly above the national average. So, and I couldn't teach it out of them. So both of those things taken together suggest that it's not really a problem with training. It's not a training gap. It's access to a structure that they lack that's allowing the faculty to overperform rather than residents underperforming because of medical knowledge issues. And then I realized, wait a minute, PCP status is a structural, this is the stuff I teach about all the time. PCP status is a structural predictor and disease activity is a biological outcome. So could this actually be related to structural inequity? Are we not framing this correctly? And so I asked again for the network to give me our data on performance. And again, another strange look, but at this point, they're finally used to this odd creature that keeps asking them for data sets. And the trend in performance looks familiar if you sort of read between the lines to what we were seeing in the readmissions data. So this is our network. The affiliated physicians groups are basically private practices. They don't like to say that up here in New England, but they're small private practices in places like Newton and Wellesley, and they're affiliated with Harvard, but they're not really teaching practices. And they're at the top, they're doing the best. Next, we have our affiliated multi-specialty care centers. These are those big, complex Geisinger type practices that we have affiliated with Harvard, who are sort of next down in the line here. At the bottom, is our federally qualified community health centers that we partner with. And then we're here, kind of at the very bottom of the middle third, the teaching practice. And if you take a closer look at what this is, it's really poverty again. It's the patients that we're serving that really dictating the outcomes. And the perverse part of this whole system is that, you know, the practices that perform better are the ones that get more money and more population health resources as sort of like a prize. And so it's a very, very backward system. And it looked awfully similar to what I had seen before. So before I move on, I'll just take a step back and tell you a little bit about HCA, which is, this is the practice that I'm talking about when I say teaching practice. This is where I work. This is where, this is no different from the practice that is at Georgetown, where I did all my clerkships. It's a teaching practice, and they're a little bit of a unique animal. They're different from community-based practices, and they're different from private practices. They're a very specific, unique type of primary care practice. What makes them unique is that they have two physician populations. They have trainees practicing with faculty. Usually the faculty are part-time. They're doing other things with their time. That's another thing that makes them kind of unique. They're usually very mission-driven around clinical excellence. And Healthcare Associates, it was founded on a dual mission of teachers and learners practicing alongside of one another with the same resources and a single standard of care for all patients. So, and this is the paper where they originally published the idea of HCA, which at the time was called BIAC, the BI Ambulatory Care Group. And so it is, you will not find two separate entries for patients that are poor versus wealthy. It really is, you know, you call the practice and you can see whomever you'd like, as long as they're still accepting patients. There's 40,000 patients, 80% of them are cared for by 60 HMFP faculty. So me being one of them. And the other 20% are cared for by 160 BIDMC internal medicine residents. And about a third of those turn over every year. So it's a very transient workforce. And the other thing that's not on the slide, but we all know, is that teaching practices are sort of known for having not the strongest infrastructure and operations. It's hard to run a practice like this, and you know, you're not always you're sort of a cost center for your hospital, so you don't always have like the most stacked staffing models. And the pandemic has made that even harder for many of us. So we're right across the street from the main hospital, and it's very much a teaching environment. So moving on to the patient-based factors. I'll just say it out loud. What do you remember about your resident clinic? When you say that to a practicing physician, they will have a very visceral response. And having spoken now to many people across the country about this, I could record the answers, and they're all the same. If you ask somebody what they remember about resident clinic, they remember the high unkept visit rate, the incredibly high psychiatric and socioeconomic vulnerability of the patients, the overstretched interpreter services. You hear this a lot. Actually, some practices do have separate entry points based on insurance. And then the last three are quotes from a study that was done actually at the Brigham, where they interviewed residents about their perspectives on their resident clinic experience. And you can see the residents really do struggle providing care for this patient population, not because they don't want to, but because it's hard to do it when there's not enough resources to do it. And as a result, our trainees really do see they see a version of primary care that looks nothing like what primary care in practice actually looks and feels like. And it's probably a different day's talk, but it's probably one of the major reasons why people choose not to go into the field. Fixing this would have much wider impact than health inequities. So we wanted to be more empirical about this, though, than just asking people their opinions. And so we measured it. And we looked at our patients along both the biological and social factors. And what we found wasn't surprising, that the residents and the faculty are caring for the same patients biologically, the same high medical complexity that the faculty see, they're seeing as well. No significant p-values on this list. But when you move over to the social characteristics, this is where you really see the difference. The trainees are taking care of patients that have much higher rates of limited health literacy, economic vulnerability. And a more recent area that we've begun to focus on is psychiatric illness burden. We're actually just beginning a full-scale analysis of this now, but this number that you're seeing here is, you can't get into this numerator if you have depression or anxiety. You have to have been diagnosed with bipolar affective disorder, a psychotic disorder, or a substance use disorder. So these are patients with very significant psychiatric comorbidities. They're more frequently hospitalized, and they're more likely to need urgent psychiatric services on the day of the visit. So here it is in a histogram. You can really see the national average of severe mental illness, serious mental illness, as I just discussed, is quite low. The residents are caring for almost 10 times that rate. And I suspect this is true in many other institutions. And so depending on the way you look at this, the residents are actually doing something critical for public health. These are patients that are systematically excluded from needed mental health care, and the only place that they have to go is oftentimes a trainee clinic. The residents are finding themselves in positions where they're prescribing psychiatric medications and doing things that are a little bit beyond the scope of their license because there's no one else to do it. And it's not because it's a problem with our hospital, it's a national problem. So moving on to the system, we wanted to know, well, what were the systems that weren't working so well? Can we get a little bit more specific about this? And so I decided we should really look at retention. We should look at loss to follow-up in primary care and see how we're doing. And so this is a multivariable analysis, and which means you throw a bunch of different factors into a regression model and you see which things are significant predictors of an outcome. And so for this study, the outcome was being lost to care. And you can see, again, the social determinants of health are coming up as small predictors of loss to follow-up, 7%, 18%, 12%. But if you look at having a trainee as your doctor, you're almost 4 times more likely to be lost to follow-up, which is a pretty big risk, right? And this is showing you that structural issue. And when we looked at it more closely, the resident rate of loss is about 40% per year, compared to somewhere around 18% for the faculty. So that means that when we do this big handover every year where the seniors graduate and they hand their panel to an incoming intern, we lose 40% of those patients right off the bat. And so this is a system problem. This is something with the operational way that we run the practice. And the final systems issue that we found that was interesting and totally under my radar was access. And for those of you who run practices, you'll understand what an incredibly difficult problem this is. But if you call HCA today and ask to see a doctor, and to say, I'd like to see a faculty member. And big thing there, if you know to say that, right? Like there's not a lot of patients who know to say that. They'll tell you that you're going to wait, best case, maybe 3 months, more like 6, or that their practice is closed. But you can see a resident within 24 hours. So all by that itself, that is going to change the dynamics of the patients who come and what they come with. So we actually interviewed our phone staff and our operations team and kind of got like the qualitative background on what does all of this mean, this access differential. And basically this is what happens. The patient calls, and if they know to ask, they'll ask for a faculty member. If they lack agency, they'll say, sure, whatever, and they'll get the first available PCP, which will end up being a resident. If they have urgency, clinical urgency, and they can't wait, they will have to go to a resident clinic. But if they have high urgency, if they have low urgency, they'll say, okay, yeah, that's fine. I'll have my old PCP continue to prescribe my losartan until I can get in with Dr. Graham in 100 months, right? So it's one of those things where you'll start to see the patients that are getting into the resident clinics have this high clinical urgency and low sense of agency. And this is actually the perfect combination for a patient with high psychiatric and social complexity, right? And on the other end of it, we have low operational capacity and poor transitional care management. We're not doing a good job here. So we're losing all these patients, and that falsely elevates the resident access and worsens this problem. And then we lose the patients and their clinical outcomes worsen. And of course, they have a whole bunch of social factors that are worsening their outcomes as well. So it's this complicated system that we've designed that's actually producing this, which is not good enough, right? So just to pull back, we talked about structural health inequities. What were the structures that we discovered? We discovered that systems of low patient agency, high socioeconomic complexity, low faculty access, and poor transitional care management were restricting access to care for patients with limited agency and high urgency into transient clinical structures. And we were actually creating this really difficult dyad between our most vulnerable doctors, which are our learners, and our most vulnerable patients. And, this is a recipe for disaster. It's certainly not a good training experience. It's not going to be the highlight of your residency. And it's a problem for many, many reasons. So is this just a Harvard thing? While I was publishing this data, MGH was publishing it too, and I didn't even know they were doing this work. And we actually kind of even named our papers similarly. So at this stage in the game, 2 centers had published this in the country and no one else. So now the question is, all right, is this a regional problem or is it really a problem nationally? Is this going on everywhere? And so we enrolled 13 other residency programs into a multi-center study, which Georgetown participated in, which is really exciting. They represent almost all of the US regions with the exception of the Southwest. We asked them for their outcomes stratified by resident versus faculty. We asked for clinical outcomes, patient demographics, access for new appointments. We looked at structural factors. There was a qualitative study and a quantitative study. The qualitative study is actually going to be published later this month, which is exciting. And the quantitative one is currently we're evaluating the results now. It's very difficult to wrangle data from 13 centers, as it turns out. And so here's what we found so far with the qualitative work. Well, all the programs are assessing resident performance. Only about 2/3 of them do so regularly as part of their operations. So they do it like in a one-off kind of fashion, but not something that you can rely on. Those who do, half are noticing these resident faculty disparities. So that indicates it's probably a more widespread problem than just in the Northeast. The majority noted that the resident clinic had higher psychosocial complexity and better access than the faculty, but no one had formally measured it except for us and that one other center. And finally, the operational structures around handoff were pretty weak, mostly relying on low effort, low impact interventions like phone blasts, postal mail blasts, things like that. And very few were measuring retention after graduation as like a quality measure. So basically, my feeling is that this is probably a national problem. I think this is pretty good evidence that that's likely to be the case. I have 4 centers with 2 outcomes here. So we have a lot of work to do on this component of the study. But you can see across the country, this resident faculty demographic difference persists. And all of these are statistically significant. And actually, as we wrap up the presentation of the data, I wanted to bring your attention to a perspective piece that was written this year. At the same time, I was conducting these analyses by a recent graduate from an OBGYN residency training program. She doesn't name the program, and she points out this phenomenon and calls it out as structural racism. And I'll read you the opening paragraph because I honestly can't say it better. We see such advanced pathology here, our guide boasted as she glided through the resident OBGYN clinic. It was 2013, and I was among a nervous gaggle of fourth-year medical students, following the resident on a whirlwind residency interview tour. We see all the Medicaid and uninsured patients, so it's like really great learning. She goes on to say that we need to begin to address this collectively if we are to meet our mission of clinical excellence as academic medical centers. And I believe that she's right on this. So before I move on, I want to remind you that when you're thinking about structural health inequities, you have to take a specific type of approach in the intervention work that you do. So a lot of the intervention work that we do is framed around equity work. And there's two kinds of ways that I think about this. There's educational equity, and then there's structural equity for patients. And you have to kind of do both. And so when you're doing this work, the paradigm is very simple in theory, but if your programming doesn't sort of believe this in their core, it's very hard to get buy-in to design systems this way. And basically, the way you do this system design theory is that you design your systems around your systems, your policies, your care pathways around the patients who have the highest vulnerability. And if you do that, they'll work for everybody. And the example I always give is, let's say, where everyone on this call is a healthcare provider and we all go to the doctor, right? So the next time you go to the doctor and you're due for a screening test, how much help from the clinic do you need to make sure that screening test gets done? Let's say it's a mammogram or a colonoscopy. You're probably Googling the phone number to the endoscopy suite, calling it yourself, arranging your childcare, driving there, and taking, that's kind of like how someone and I say physicians because we kind of have the peak health literacy, right? So anything the clinic is going to offer us to help with scheduling, we're probably just going to pass on. But as you move down that ladder of health literacy, if you design the system so that it's, multilingual services at the point of exit from the clinic with instructions in 3 different common languages with pictures at a 8th grade reading level. And then there's a routine follow-up phone call in 24 hours in evening hours outside of the workday. And then we also will give you a cab voucher. So if you design your structure like that, people like us will sort of pass on 99% of it, but the folks who need the box to stand on will take it, and the system will work for everybody. So that's kind of how we think about it. So how do you provide educational equity? What does that mean? To provide educational equity, we as a practice have to try to ingrain into our programming that everything we do has to be designed around a physician in training and a constant influx of inexperienced doctors. You will never train these doctors up to a level because another group will always come in the following July. So you have to create these very agile systems that have a training model embedded in them so that physician can function in the practice. How do we do that? So I'll show you some of the examples that we've done. This is some of our intervention work. So we teach population health for the residents in a very specific way. So for me as a faculty member, population health is something that happens behind the scenes. I don't even know what's happening. People are calling my patients who are overdue for tests. They're helping them schedule those tests. They're calling them when they're overdue to see me and popping them into my schedule. Once in a while, there'll be a note in there, but mostly this happens behind the scenes. That can't be how you design it for residents. So because residents are trainees, you have to take the things that are happening in the background and put them into the foreground and be very intentional about how you teach them how to interact with that system. And so what we do now is every Monday morning of your ambulatory block, you have a 2-hour time frame where we do the population health curriculum. And the curriculum has didactics in it. We cover things like population health 101, social determinants of health, health equity, anti-racism, but the second hour of it is actual experiential curriculum where the residents get their performance data, they look at it in aggregate, they're able to stratify it by faculty versus resident, compared to their peers, by race, by English proficiency, so that they have their hands on it and they're actually experiencing this in a way that sticks, right? And then they work directly with a population health specialist to identify action plans for patients who are overdue for tests or need follow-up. And we do this thing where at the beginning of each academic year, we give them a list of their patients who are lost to follow-up. And then they get a half a day of telehealth to just call those patients and offer them an on-the-spot visit if they'd like it to get them back into care. And initially, we thought this was going to be an operational disaster, but what the residents ended up learning from the patients during those phone calls, honestly, could never have been delivered in a formal didactic curriculum. They found out the reasons why those patients were lost to follow-up, what the barriers were, and had time to kind of talk to them and help them sort it out, and resources at their fingertips to actually do that work, so that they didn't leave that session with just the moral distress, but also a sense of efficacy. We also do pre-practice huddling. So a lot of what the preceptors do with the residents is very focused on medical knowledge. And we forget that the residents don't always know how to use the practice, how to use the resources that we have. So for the 30 minutes before the start of clinic, they report and we do agenda setting for each visit. We teach them how to do that so that they know how to practice ambulatory care. We teach them how to use the practice for the issues that the patients of the day are coming with. We identify open care gaps and come up with a plan for them. And then, of course, the disease and complaint-specific teaching happens naturally. But this is really a forum for the how to practice medicine, not what to practice curriculum that needs to happen. And this also allows us to really focus on preceptor continuity. So it turns out that the more you work with your assigned preceptor, the better your care. So what you're seeing here is rates of cervical cancer screening and preceptor continuity. And there's a direct and statistically significant relationship between the two. So by forcing people to kind of come together to huddle, you're also laying the groundwork that they should also work together for the rest of the day. And we do this thing called the Preceptor 360, which is like an educational report card for the preceptors. Building effectiveness in caring for resident patients right into their standard feedback and evaluation. 360s are normal in the rest of the world outside of medicine. This is a really common way that people provide feedback. It just allows you to get feedback from multiple domains. So the preceptors are getting their educational feedback, they get peer feedback, and then they also see their resident performance compared to their own. They see their performance as preceptors compared to their peers in terms of continuity and how well the resident patients are doing. And we've just started to integrate this into their quality incentive bonuses as well, which is a really, really important, risky, not so popular, but really important component of getting this care to improve. And again, this is a topic for a different day, but we just recently published our primary care track, which is a really interesting model. If you think of it as not a primary care track, which is a different way to train medicine residents, these 12 residents spend 6 months a year in the outpatient setting, and their outcomes are better in terms of caring for patients. So I think this is just how all internal medicine residents should train. You're all going to be, most of you, 80% of you will be outpatient doctors someday. So you should be spending more time in this environment and you'd be doing better by your patients if you did. So how do you provide structural equity? This is harder because I don't have as much control over this, right? I can do whatever I want with the residency program, but I have to figure out how to do this with hospital leadership and Department of Medicine leadership and then division leadership. You have to sort of think about who your audience is and make sure that you're framing equity not just as a just cause that you believe in, that's part of who you are, but also important for the work that they do, right? So integrating it into your financial bottom line and into your QI culture, I think, are two ways to really make sure that you have your leadership behind you in this work. And population health infrastructure is my favorite thing to say is it's a tool for equity intervention work. So I'll go through these. This is our outcomes and this is our patient loss. This hurts your bottom line. These are lost quality incentive dollars, and these are panels not reaching target. So if you create financial models for both of these, you very quickly can get the attention of hospital leadership, which we've done, and it's incredibly effective. When you're in front of your QI people, these are delays in diagnosis of cancer or earlier onset of heart disease. And these are open diagnostic loops. This terrifies QI people. So when you lose a patient, you're losing them with their Barrett's esophagus biopsy that they had last week, right? Which might be esophageal cancer in 2 years. So you can equate these to patient safety events as well, because they are. And population health is, I think, the best way to do equity work, because it's all about accountability and transparency. So in population health, what we do is we make populations, and then we create systems and structures and routine, practices around those disease states. And so what I've tried to do is convince my division that the resident population is a population. It's a population with unique risks and unique demographics that needs a specific type of care model. And so what that means is now I have a resident panel registry, and I can feed the metrics that I care about into that registry and review them with the leadership team quarterly, and have people be accountable to the outcomes of the resident patients. I can look at things like not just the performance, but the performance compared to faculty and by race and ethnicity and language. I can look at retention after graduation, so we know exactly which patients are leaking out of the system and pull them back in. I can look at preceptor continuity. And I can create this thing called the return to care registry, which is basically just a fancy way of saying that if we don't see a patient 12 months after a resident graduates, they have a specific outreach strategy that the practice will use to pull them back in. It looks pretty fancy. And it's really effective. So I think this is why, when you're able to sort of hold people accountable and see the data, it changes the way people think. And this is actually our preliminary analysis. So we've done all of this intervention work, kind of went in as a bundled set of interventions in 2020, which was terrible timing because of the pandemic. But I actually think there's a really amazing story in this data. So what you have here are diabetes outcomes and hypertension outcomes. Blue lines are faculty, orange lines are residents. 2019 is before the pandemic. 2020 is during the pandemic. 2021 is the next year after the pandemic. So take a look here first. This is pre and post COVID. Look what happened to the faculty patients, right? Exactly what we all worried about. All the outcomes were going to go down. All the hard work people did, the control of disease was going to worsen. That's to be expected. Look what happened to the resident patients. Nothing. The conditions that they experience are like having a pandemic if you're a faculty patient, which is really profound if you think about it. There's a pretty much flat line in both of these. And so then when we start to infuse equity, which are interventions where we are focusing on the resident patients got priority scheduling for in-person care when we were just doing 50-50. They got priority outreach. We were risk stratifying them for risks for loss and reaching out to them. And you can see that the faculty patients are kind of starting to recoup on their own but with equity, you can see that the resident population comes up nicely. And the slopes of these lines are actually greater than the slopes of the lines for the faculty. And so we don't have the 2022 data yet, but I'm excited to see where we landed after 2 years of doing this kind of work. It was supposed to be at SGIM, but I was just too worried to go. So that's where I'll end. I'll just end by saying a few things. One, that our built educational and clinical structures do have the risk of creating barriers for oppressed groups. And if we're not actively working against that and thinking about it, if we're being passive and just sort of letting systems evolve, you will find evidence of these eventually. So it really is an active process for a practice. You have to measure for it, look for it. You have to look beyond aggregate outcomes, really looking beyond just looking at your data in aggregate and making sure that you have a reflexive. I also want to see that data distributed by the groups we care for that we're worried about. You prevent it by using the design strategies that we talked about, where you design around, you center on the individual with the highest vulnerability. And if it works for them, it works for everybody. When you intervene, you can use contributing factor analysis. Hopefully you have a good sense of how to do that now. Integrate this into your financial bottom line and your QI culture, and use population health management as a tool. And then finally, remember to integrate your professional identity. It's where all of your power lies.